Class, it's Dr. Matilda Carlo and my dog Bentley that is coming to join us too. It's National Pet Day, so that's okay. Hey, so I am posting our lecture for talking about hospice. This is one of my very favorite lectures. We're going to talk just about the team today and what hospice really is and some of the requirements. And then next week, when we're in class, we will talk about, we'll actually talk about some of the barriers to end-of-life care planning and specifically hospice. So you'll see that this PowerPoint is not my usual 5 to 8, 10 slides. It's super long, and that's because I did a presentation for Capella University on this for one of their classes. So everything flies in, and there's lots of information. This was with a colleague of mine, so just wanted to let you know we'll skip over some of these, like the objectives. We're not going to worry about that. Okay, so first and foremost, it's really important to remember that hospice is really a philosophy of care. Oftentimes you hear people say, oh, this person went to hospice, as if it's a place. And hospice is a philosophy of care that can occur in multiple different places. So just keeping that in mind, that it's not necessarily like you go to acute care or that kind of thing. It can occur, the type of care, hospice, can occur in lots of different places. It's a philosophy of care that focuses in on pain management and symptom management. So you should ask the question, well, if it focuses in on pain management and symptom management, why isn't it just called palliative care, which is really what palliative care is? In hospice, there's not only this focus on symptom management and pain management, there's also a requirement that the person no longer be taking or getting curative treatment, but that there's a shift in what our goal is. And this is sort of the fundamental shift of hospice, is that we're moving away from curing a disease to managing the symptoms of the disease. So the goal is to not hasten death in any way. And that becomes really important when we start having conversations about death with dignity. Hospice is not in the business of hastening death in any way. And it's also not in the business of extending life in any way. What it is in the business of is making sure that people have the best quality of life that they possibly can for whatever time they have left before they die. So it's really a philosophy of care. It focuses in on pain management, symptom management, and providing comfort and dignity. And when we talk about dignity, we're really talking about, like, what do you want to be doing with the end of your life? Like, what things would you want to be engaged in within your physical capabilities, and can we make that happen for you in some way? So I'm going to tell lots of stories about kind of how my experience in working in hospice, and so that you can kind of see what we're talking about. In hospice, the patient is actually in charge. And I know this sounds strange, especially because, in the 90s, we sort of had this patient bill of rights, where the patient is really in charge of their care. And then we see in acute care hospitals that although we give out the patient bill of rights and we say that people have to sign consent and have informed consent to have things, procedures done and treatment done, oftentimes the patient doesn't end up really feeling like they're like at the center of their treatment and in charge of their own care. In hospice, they really do own their care. They get to choose what they want and what they don't want. And this becomes really important when we're talking about end of life, because at end of life, people have particular values and particular things that are impacting what they want this process and this part of their journey to really, really look like. So If a patient says, you know what, I had a history of substance use and abuse, and I really, really, really don't want to have any narcotics because I'm afraid of relapse at this point in my life, then we will make sure that we treat them not using narcotics. We will make sure that their wishes are really what we're doing as far as meeting the goals of keeping them out of pain and keeping their symptoms under control. So the patient's really in charge. So one of the requirements that differentiates hospice from palliative care is that in hospice, a person needs to have so in palliative care, which is something that oftentimes gets mixed up in the literature, in palliative care, a person could come in and be diagnosed with, say, pancreatic cancer, and then decide that they're going to go through a round of chemo or radiation to treat that cancer. In palliative care, they could start palliative care the minute they were diagnosed with a life-altering illness. And so the palliative care team would work with the acute care while the acute care team is working to help come up with a treatment plan to cure the disease. The palliative care team would work with them to come up with a way to manage the symptoms that they might get, skin burns from radiation, or the nausea, or the reduced sensation or feeling in their nerves. They would work with them to manage those symptoms while they were going through acute care and curative treatment. In hospice, though, we say we're going to do all those things to manage the symptoms that they may be having, but they're not allowed to continue in acute care or curative treatment. So you can imagine that this becomes a barrier to accessing hospice services because a physician has to actually certify and sign a certification that says that it would be reasonable that this person could die within 6 months. So what happens if a physician signs that and then the patient doesn't die in 6 months? Absolutely nothing. We look at recertification first at the 6 month process, at the 6 month mark, and then after 6 months, every 3 months, we reevaluate to see if the patient is still appropriate and it's reasonable to think that they could die within the next 6 months. And if it is, then they just get recertified and continue in hospice. I say this because it's really important because oftentimes this is what prevents people from coming into hospice services and not being able to access this whole hospice world because of this 6 month time frame. Physicians many times are reluctant to say that someone has 6 months or less to live. And that kind of makes sense when we've talked before about how we live in a culture that's very cure driven and focuses in on trying to extend life to say, well, this could be, they probably would die in 6 months, would really, physicians oftentimes say, well, I can't say that. I'm not God. I don't know. Again, there's not a ramification necessarily. There is with insurance that we have to kind of look at, but physicians don't get in trouble per se if this isn't the case. So, but very important for us to remember that this is one of the qualifiers in order to access hospice services. See, things are flying in on my computer here. So I'm going to just bring some of these in because I want to make sure we have all the information. So just to give you a little historic background, I'm not going to get into a huge philosophy discussion here, but just important to remember that when we talk about hospice, it really kind of stems way back when we used to not see a difference between sort of like holistic mind-body care. And so medicine was really done by healers for a very long time, right? And so if you were ill, you would go to a medicine man and they may treat your physical symptoms, and also there may be a spiritual element to that. But there was no disconnect between our mind and body. And then we sort of wanted to, right, start moving away from that into making medicine a hard science. And so that was the pull away. And so medicine increasingly became, quote unquote, hard science. And we moved away from medicine. Men and also churches used to provide a lot of physical care for people and treatment for people. So we moved away from that. It's interesting because there's been a huge push, as all of you all know, to reunify the mind-body holistic approach in medicine. And so we've kind of, in many ways, come full circle where we now say, well, no. We know that we can't separate these two things. And that's not reasonable. And we have to do a more holistic approach. So hospice is really sort of came out of this historic root of really mind and body, that we wanted to treat people from a scientific perspective. We wanted Dr. Sanders, who was the originator of the first hospice, wanted very much to root hospice care in research. And again, we know, right, from Kubler-Ross that was something that back in the 60s, or before the 1967, we didn't really talk about at all. And so to do research on what is helpful for people as they're dying was unheard of. So Dr. Saunders really wanted the staple of hospice to be based in research. And then also remembering that we can't differentiate between mind and body. The goal was not just to treat physical pain and physical symptoms, but to acknowledge that there are very real psychological processes that are happening in the dying process. Sorry. Okay. So this is really the connection that we have between sort of our historic roots in medicine to now with hospice, who again is really focusing in on a more holistic approach. So when we look at the hospice movement in 1967, the first hospice was created, St. Christopher's Hospice. Dr. Saunders was the founder of that hospice. And then, right, 1964, Kubler-Ross publishes On Death and Dying, which brings this issue of dying and how to do this well into the forefront of the nation's hold on. Into the forefront of the nation's consciousness, if you will, about death and her sort of groundbreaking research and book on death. Then in 1970, the hospice movement spread to the United States, and then the first hospice was created here in the United States in Connecticut and New Haven. Then, of course, as we all know, nothing really takes movement and starts really blossoming until Medicare comes on board. So in 1982, Medicare passed the Medicare Hospice Benefit Clause. And basically what that means is, and this is an important piece, is that when someone goes into hospice, their regular Medicare that they have is switched out for a Medicare Hospice Benefit Clause, which means that everything that hospice provides is covered under Medicare. but not their normal Medicare. They switch it out for the hospice Medicare. So it's a little clause that it creates sort of another little benefit package. The key here is that when someone comes into hospice and they start receiving hospice services, they have to switch out their Medicare package that they would use for acute care and for curative treatment. So it's just a switching out. Now, if someone goes, say someone comes into hospice and they have pancreatic cancer, and so we get rid of their normal Medicare and they start using their Medicare hospice benefit. So all of their durable medical equipment, all of their care, physician care, nursing care, home health care, social work, everything is covered, including their prescriptions and everything else. And that's what they end up using. Now, let's say that this person comes in for pancreatic cancer, they're using their hospice benefit, and all of a sudden they fall and they break their hip, okay? They can access their regular Medicare coverage to have curative treatment for their non-hospice diagnosis, okay? So they would be able to go have a hip replacement or something like that, as long as the reason that they're accessing curative treatment is not for the diagnosis for which they have been admitted into hospice, okay? So I've had patients before who come into hospice, they start feeling a lot better because their symptoms are managed really well, and all of a sudden they say, you know what, I would like to go back and do this clinical trial to try to cure my terminal illness. Then they can drop out of hospice. They can say, hey, I want to switch back and get my full Medicare coverage again, and they can do that. So just remember, none of this is permanent. It can be switched back and forth as needed. There are actually right now some trials out there where they're doing some research to see about allowing people to have hospice care and not switch their medical insurance coverage to a hospice clause, and allow them to still be able to have curative treatment while they're in hospice. That is not the norm. That there is a research study specifically. I know that Gilchrist is in process with that, so that they can do more of a palliative model where they can help with symptom management and pain management while they're still getting curative treatment. And that way, if the curative treatment does not cure their disease, they can transition to full hospice care very easily, and they'll already know the team and be receiving care. So that's not the norm, but there are some studies out there right now. So let's just talk a little bit about the elements of hospice, and we're going to review some of these and then more specifically go over them as well. So the important piece here is the patient and the family are viewed as sort of the patient unit. When you go into an acute care hospital, you're really the patient, right? You go in, you break your ankle, something happens like that, and you're really the patient. Not so worried about what's going on with your family. And unfortunately, that's the case even when it's something more, a devastating diagnosis, is that we really do just focus in on the patient and not so much any wraparound services. We might have a family meeting here or there, but our focus of care is on the patient. In hospice, that's not the case. Our focus is on managing symptoms and pain control with the patient and emotional support for the patient, but we really extend that so that we can also focus in on the family unit. The family unit is very broad. So there were times when I was working in hospice, and this is really how this kind of works, is that, maybe a mom is dying and she has a young child who's in elementary school, and she identifies that the school and the little Johnny's having trouble in his class. Maybe as a social worker, I go out to the school to help the teachers, and maybe even little Johnny's class understand what's going on and how to best support Johnny while his mom is in this process. So the family unit can be anyone who is identified as maybe needing some support and some wraparound services. I've many times had, a best friend, a family member, an extended family member, a senior center who is potentially going to be losing a member of one of their groups or their clubs. So that unit can be very creative, and it doesn't really focus just simply on the immediate family or just the patient. It's anyone who's identified as needing some services. The other thing here is that the hospice is very interdisciplinary. Notice that it's not spelled correctly, but it's very interdisciplinary. And what I mean by that is that every member of the team comes to the table and they really, they report on how they think things are going with the patient and the family unit, and they all play a very integral part. I know we say this in acute care oftentimes that it's interdisciplinary, but in hospice they kind of take it to a new level because they really do appreciate that we are focused on physical pain management and physical symptoms, but oftentimes in order to treat physical pain or physical symptoms, we need to get to an underlying cause of some social pain or emotional pain that is going on, or spiritual pain. And so it is very interdisciplinary. And one of the things that I love about hospice is that there are times when someone is not receptive to my services because maybe they don't have a social worker, or they're not receptive to social work coming in and being helpful. But they'd be receptive to the chaplain coming in, or they're receptive to a home health aide coming in. And we can be part of the team by coaching those other professionals on how to be helpful and supportive to the patient. So really, we all work together. I've already mentioned the symptom control. The thing I want to just mention here is that oftentimes folks come into hospice having right on the back of having had curative treatment. And so they have a lot of symptoms that are related not so much to their actual disease, but to the treatment that they were having for the disease. So case in point, chemotherapy. Oftentimes, so the reason that people lose their hair and their ability to taste is that chemotherapy kills fast-growing cells. So anything that's very fast-growing, like hair or taste buds or things like that, will, or sometimes the GI lining, that kind of thing, they're very fast-growing cells, and so chemo targets fast-growing cells. When you stop chemo, right, people start being able to taste again. Sometimes the fatigue goes away. Sometimes the neuropathy that people may experience, where they constantly feel like their feet are falling asleep or their hands are falling asleep, sometimes that goes away. And so they get into hospice and they say, oh my gosh, I think I'm getting better because my symptoms feel so much better. When in reality, the symptoms that we're managing were due to or from the treatment that they were receiving. Okay, so also volunteers are an integral part of the whole hospice team. So integral that if you don't have a volunteer coordinator, then you can't get Medicare reimbursement. You have to have that. And as when we talk more about volunteers, you'll see that they are such an important piece of hospice and really do focus in on pretty much anything that we might identify that the patient or family needs. They jump in to help. Okay. Acceptance into hospice is not based on their ability to pay. I mean, this is maybe a little idealistic, but in general, patients will, there are charitable funds that can be used for hospice care. And different hospices sort of have different regulations about how much funding they have for charitable care. It used to be that Joseph Ritchie, which was right down the street from over by Maryland General, that they had it was a hospice for adults, and right here in the city. And if someone had, just qualified for medical assistance or had turned in their application, then they would. And they would be able to access hospice services. And so we knew that they could go there. Whereas other hospices may have charitable funds, but only take one bed for someone who couldn't pay. So this is somewhat idealistic, although they do usually say that their goal is that acceptance into hospice isn't based on one's ability to pay. The other piece here is that hospice is care that is available 24/7. It's really important to kind of understand this, is that hospice care, if you're at home and receiving home hospice, there's not going to be a nurse or a home health aide or any hospice worker at your home 24/7. They're not even going to be there for 4 or 5 hours a day, but they will be available to the family 24/7. So what that means is that one of the requirements when you come into hospice is that you must have a primary caregiver. You can't come into hospice if you don't have an identified primary caregiver. And that identified primary caregiver is going to help coordinate making sure that you have all the care and services that you need. And there's a nurse manager on the hospice team who's going to help with that as well. But it's important to remember, sometimes folks say, well, I'm going to get hospice to come out and they're going to have someone at my house all the time to help. That's not the case at all. They're a phone call away should there be a crisis and you need someone to come out, or if a medication needs to be changed or a symptom emerges that needs attention. They're available 24/7, but they're not going to have any staff member at your house 24/7. Another piece is bereavement services. The way that it works in hospice is that the social workers, before the patient dies, when the patient is admitted into hospice, will work with the patient and the family. Much of that work is around emotional support and helping the family sort of prepare for this death, and working through that. Once the patient dies, the social worker will hand off the care of the family for bereavement services to a bereavement counselor. Oftentimes those folks are licensed as an LPC or a social worker, but they will take care of the family after the patient dies. So, so there's really two sort of mental health folks who are on either side. One is before the death and one is after. And they don't usually cross over. So we'll talk more about bereavement services and what they do. There is home care and also inpatient care that is coordinated by the whole team, and there's lots and lots of support staff. So let's talk a little bit about where people can get hospice care. They can get hospice care in their home, which is by far the majority of folks say, I would like to die at home, and I want to receive all of my care at home. And so nurses and the whole staff will come out and do home visits and provide care there. There's also a community-based model, which not all hospices have. Gilchrist on the grounds of GBMC is lucky enough to have their own building. And if you've never been over to Gilchrist, it is gorgeous. It's like a little Swiss chalet right on the grounds there of GBMC and Shepherd Pratt. And it's an inpatient facility. So folks can come into hospice and go to the inpatient facility. It's not like a hospital at all. It's like all hardwood floors with fireplaces. All of the rooms are private rooms, and most of the rooms open on the inner section of Gilchrist open. They have French doors, and they open to a beautiful courtyard where the patient can be rolled right out in their hospital bed into this gorgeous courtyard. I mean, it's like something straight out of Snow White, okay? Like there's deer and there's birds and it's beautiful and there's a memorial garden and it's just absolutely gorgeous. On the base floor, they have a children's hospice where they treat for pediatrics, and again, all very kid friendly and kid oriented. They have a kitchen that family members can say that they want to cook a meal and come in and bring the ingredients and cook right there on site. There's a chef that if you don't want to cook, but you have a family recipe that you want to have made, you can coordinate that, and the chef will actually make your family recipe if you're willing to give it up for you. I mean, it is absolutely amazing. Not all hospices have a community-based freestanding hospice to use for inpatient, and so sometimes there will be a hospital unit that does not, it's just like a regular floor on the hospital unit that is just hospice care. So GBMC has a hospice unit. It looks a little bit like an ICU, but there's much less equipment and things like that. They try to make it a little bit less hospital-like, but patients can receive not curative care, but hospice care on that one particular unit. So that's also a model. Some hospices, like Seasons Hospice, they don't have a freestanding inpatient facility, so they use hospitals to bring people into specific units where they will provide care. And then also, there are many times when we use an institution-based model, and that's where someone might reside at a nursing home or an assisted living, Oak Crest Village, those types of, or Pickersgill rehab centers, and they may reside there, and they have all the services that are already there, and then hospice comes in and provides services on top of that hospice care to the patient. So again, hospice is a philosophy, so it can happen in any of these four combinations. The thing to remember, just to keep in mind, is that sometimes folks will say, well, I don't want to die at home, so I would like to go to the community-based hospice. Okay. What the push has been in more recent years is that if someone's symptoms can be managed at home, then their care is going to be covered in the home. But the room and board, if they should say, well, I don't want to die at home, I want to go to a rehab center, or I want to go to a community-based freestanding place, then what would happen there is that if they could be managed at home, but they just don't want to be there for whatever reason, then the hospice care will be covered by Medicare, but the room and board would not be. So folks that are receiving hospice care in a nursing home, they still have to pay the room and board for the nursing home, but their hospice care would all be covered. That makes sense. So sometimes what we see happen is that folks will come into home hospice, and somewhere along the line, they have a symptom that's challenging and they can't quite manage it at home, and they need to kind of bring them into somewhere they can be observed, and they can have nurses there right on hand 24/7. And so what they do is they will have them come in and work to get that symptom managed. And then as soon as the symptom is managed, they'll send them back home. And then hopefully it'll be able to be managed at home. Sometimes folks, when they get really close to the end of their life, they usually within like 42 to 70 or 48 to 72 hours, there'll be some increased restlessness, possibly increased pain that can't be adequately managed at home, or sometimes it can, but families are very uncomfortable with that. And so sometimes people come in right as they're sort of like actively dying, as it would be called, and they can be in an inpatient facility for that last few days of their life. Another piece of this too is that one of the things in the Medicare hospice benefit, and again, private insurance also sort of mimics whatever Medicare is doing. So one of the benefits is that there's respite care. So if a family was planning a vacation and they still want to go on their vacation, they can have their loved one come into a nursing home or rehab center, and it would be covered for a 5-day period under the hospice respite benefit. So this is huge for caregivers that have been caring for a loved one for a really long time and just need a break. They need a few days to just sleep. They had a vacation. Someone's graduating from college in another state. So they just need somebody to help take care of their loved one while they go do whatever it is that they need to do or would like to do. So there is a respite benefit, and that would cover the room and board and the hospice care. Usually it's for about 5 days, and you can do it once every few months. So that's something that we can coordinate as well. Okay, so now we're going to walk through the different team members and talk a little bit about what they do. And my goal is that for today, we're going to talk about the team and what that looks like, and then also talk a little bit about pain, and then pick up with the rest next week. So as I already mentioned, there's an interdisciplinary team that each team has a group of professionals who all come from different disciplines to really help provide and come up with a good treatment plan. There's a primary nurse who is really the one who coordinates all of the care. The great thing about hospice is that when a patient comes in, there's like a set of orders that the physician signs off on, that the nurse doesn't have to call every time they need to increase a dose of medication. They don't need to call and say, oh, I need an order to get a commode, and I need an order to get a hospital bed. All of that is already taken care of, so that they can get all of those things in place that someone may need. Usually, I'm going to keep on going. There's a nurse who is sort of the manager of all of the care. So that nurse will come out to the home, assess the patient, change medication when needed, order durable medical supplies, all of that, and really be the coordinator of all of everything that needs to happen. One thing that I would say here that's really important is just like prescriptions. I don't know about you, but when I've worked with folks who are in acute care and they just need to get a prescription, but you're caring for someone who can't be left alone. It's really hard to get to the pharmacy. When my grandmother was dying, my grandfather had such a struggle, just like, I can't leave her because she's got dementia. I don't have anyone to come sit with her, but I need to go get her medication. And so how am I going to do it? Like, I'm going to have to like get her to get in the car, and then we drive there, and then I have to bring her in the store. Like, it was just such a rigmarole, that when hospice came in, it was just such a relief that the medications, when there was a change in dose or a switch to a different medication, the medications arrived at his door, and he didn't have to go anywhere. He didn't have to figure out care for her or a ride or anything like that. It was just delivered. And it's the same with durable medical equipment. So, when someone needs a hospital bed or commode, oftentimes as a case manager, like in acute care, you need to get somebody a walker or a commode, and it takes like an act of God for the insurance company to say, yes, we'll prove that and we'll pay for it. It is so challenging to get those resources in place for people. In hospice, again, it's all covered. So all of that is available, and the nurse is taking care of that. I want to just flip that on its side for just one moment and remember too that one of the barriers to hospice is that sometimes we as hospice professionals are so excited about all the resources that we have for people that we fail to step back and really look at the ramifications of implementing those services. So what I mean is, oftentimes people will say, I'm okay with being in hospice. Like, that's okay. Like, I've come to resolve about that. But as long as I don't have to be in a hospital bed, I'm okay. Or as long as I don't have to use a commode, I'm okay. As long as I don't have to sleep in the living room because I can't make it up the stairs to the bedroom, then I'm okay. And so sometimes getting this equipment that really ultimately is very helpful for the patient has a psychological milestone attached to it. And so we need to be very, very careful about that. We need to be assessing for how receptive people are and what it really means for people that they are now in the living room, in a hospital bed, on display for their whole family, or having to use a commode, and they have had not only to adjust to their illness, not only to adjust to their terminal status, not only to adjust to the fact that they're going to die and that anticipatory grief that they're experiencing, but now they've lost some of their daily activities of daily living. They can't take care of themselves. They can't shower or bathe on their own. They can't go to the bathroom on their own. And so we really need to be aware of those milestones for people. Okay, there's a medical director. This is also an important piece to remember is that if a patient comes into into hospice, their primary physician who's been treating them, maybe it's their oncologist. We talk a lot about cancer because that's one of the primary diagnoses that come into hospice. Maybe their oncologist wants to continue to be their primary point person for hospice and wants to write the orders and wants to still be in charge of the patient's care. Then they absolutely can do that. If they choose that they don't want to do that, then that is okay as well. And there's a medical director who will take over and really be the person to write orders and take care of the patient's care. So it can go either way, and oftentimes physicians are reluctant to give up the care of their patient or refer to hospice because they don't want to give up the care of their patient. And that's actually not true. They don't have to. They can still be the person who writes the orders and does everything for the patient. It's really up to the doctor and the patient. There are also home health aides, and they help with ADLs and things in the home. They'll help teach the family how to give their loved one a bath, a bed bath. They'll help teach the family how to get them up to the commode or up to the bathroom. They'll teach them how to feed the patient if there's some challenges with swallowing or, whatever it may be. They will help out with that. One thing to just kind of hover here on how important the home health aides are. There are times, like I mentioned before, that a family might say, I don't want to have a social worker come in. I don't have anything I want to talk about a social worker with. Okay, instead of me challenging that resistance, I might help the home health aide, who then comes to me and says, this patient was crying when I was there. They're really having a hard time. They're really struggling and feeling depressed. I might then coach the home health aide on how they can help. But the home health aides are just amazing, because when you have someone who is caring for you in such an intimate way, they're giving you a bed bath or they're helping you use a commode, there tends to be conversation because they're so vulnerable. Patients are so vulnerable that the home health aide might be the person that the patient feels most comfortable with and just is willing to be vulnerable about emotional responses as well. So really important that we remember that. It doesn't have to be me as the mental health professional that provides the support. I can be the coach to help someone else provide the support if that's how the patient is willing and wanting to get that support. We already kind of talked about this durable medical equipment. The nurse will get all of that out there, but it's delivered and set up for the patient so that the family doesn't have to do anything. They point and say, we need to move this couch and put it over there, or put the hospital bed there, and they will do that. Durable medical equipment will help take down a regular bed, put up a hospital bed. They will take care of all of that. And then once the patient dies, they'll also come and get the equipment, take it apart, and get it out of the home. Again, psychologically, that is a challenge, and it's a challenge we need to, as social workers, be assessing and talking about, because more times than not, I have heard from families like, I'm dreading when they come get the hospital bed. Like it's the last piece of my mom that I have, or it's the last, whatever that may mean for them. We need to be very careful that we are helping them sort of psychologically prepare for what that's going to look like and how challenging that may be for people. Okay, so social workers and counselors, to flip through these, we're there to provide emotional support. We're there to help them sort of talk about their fears and anxieties about this dying process. We're there to help protect their rights and make sure that they are the ones dictating how they want to die and what they want that to look like. We're there to help make sure that the highest ethical standards are being practiced. Now, and this may sound, strange, because of course that's what we always do. But I've had folks come into hospice. One particular that I was a consult for had a young adult come in who had some developmental delays and had Down syndrome and was diagnosed with non-Hodgkin's lymphoma, and they were trying to get him into hospice. Well, his non-Hodgkin's lymphoma was extraordinarily treatable, so much so that it could barely be even considered a terminal diagnosis, because there are cures for that. But the parents were getting older and said, I would rather him die of non-Hodgkin's lymphoma before I die than to have him be treated and then have to go into a group home and us die because they were getting older. So that was a huge ethical issue, which we had to refer to an ethics board. And eventually he did not come into hospice, and he received a guardian and got treatment, curative treatment. But that's the kind of thing that we need to be aware of, and making sure that we're protecting the rights of vulnerable populations. And then we're there to help support the emotional needs of families and patients. And so again, that's part of our assessing who needs the emotional support, we're not there to to diagnose someone as bipolar or having major depressive disorder or anything like that. We're there to provide support on this journey that they're going through and identify risk factors that might impact people's grieving process so that they can have access to care through bereavement services after their loved one dies. After someone dies, the family or anyone in the identified unit can receive bereavement counseling for 13 months after the death of their loved one, and it's all covered under the insurance. So it is available to whomever for 13 months after the death. Usually what happens is in the first month after the death, the bereavement services will send a card, and then in 2 to 3 months, they'll actually make contact with the survivor and ask them if they want to come to any support groups, let them know about the availability of support groups, and or come in for grief counseling if needed. Chaplains. Chaplains are amazing. And they're really there to help support the spiritual needs of patients. Sometimes they help do funerals, they do memorials, but more so than not, chaplains will be there when we start hearing people who are really experiencing some spiritual disillusionment. They will be available to provide services and come out and support them as they're questioning, like, why did God let this happen to me? What's going on? I can't understand what I did to deserve this, or I don't know what happens after I die, and I think nothing happens, and I'm scared about that. And all of those things, the chaplains are who we can pull in to talk with a patient more about that. The volunteer coordinators, again, they will have volunteers come in to do haircuts, have massages, paint people's nails, shave, give people a nice clean shave, to read books to people, to play music. I mean, anything that you could possibly think of, the volunteers will coordinate that. I'm going to give you some examples of that next week when we talk more about hospice, about some of the amazing things that volunteers have helped have happen for patients that really helped the family and the patient in this process. Actually, I'm going to stop there. There's a lot of information on music therapy, but we got to types of pain, and we'll talk more about that and some of the cool creative things that we've done in the past for patients. But for now, I'm going to leave that for you, and I will see you next week.